Welcome to today's Focus on Aging Federal Partners webinar series. Next slide, please. Our webinar today is entitled Promoting Healthy Aging to Reduce Dementia Risk as a New National Goal. Next slide, please. If you have questions today that you would like to submit to have them answered, please click on the live feedback button, as you see here on the slide, right beside this big yellow arrow at the bottom of the videocast page to submit your question. We will take all questions at the end of the session, and we will do our best to get through as many of those as possible, in addition to some of the questions that you submitted to us in advance. Next slide. I'm Dr. Lisa McGuire from the Centers for Disease Control and Prevention, and I will serve as your moderator today. Next slide. The National Alzheimer's Plan that we're seeing here on the right-hand side of the screen has had until 2021 5 very ambitious goals. Next slide, please. In 2020, the Advisory Council asked myself as well as some of my colleagues to form an ad hoc subcommittee to explore the evidence on risk reduction and to present our findings and our outcomes to the Advisory Council during the July 2021 meeting. Next slide, please. I served as the Federal Advisory Council member to lead this effort, and I enlisted a couple of my colleagues from other organizations. First, Matthew Baumgart, who's Vice President of Health and Policy at the Alzheimer's Association, and Kelly O'Brien, who's Executive Director of the Brain Health Ecosystems at Us Against Alzheimer's Disease, to serve as the co-chairs. We identified 8 work group co-chairs that I'll show you in a second, and we collectively identified the risk factors that we wanted to examine, as well as invited people based on their expertise to join this work group or these work groups. Next slide, please. The first work group that you see here was led by Dr. Joshua Chodish and Dr. Jewel Mullen, and they looked at obesity, diet, sleep, and traumatic brain injury with a series of experts that they invited. Next slide. The next work group was led by Dr. Lori Wetzel and Dr. Carolina Coates, and they looked at physical activity, tobacco use, and alcohol. Next slide, please. The third work group was led by Joe Chung and Dr. Marilyn Albert. They looked at social isolation, depression, hearing loss, and cognitive activity. Next slide, please. The fourth work group was led by Karthik Savakanar, Dr. Rebecca Goetzman, and they looked at hypertension, hyperlipidemia, and diabetes. Next slide, please. While we don't know for certain what, if anything, can prevent Alzheimer's disease, we do know that there's some good evidence to suggest that there are several modifiable risk factors that might lower a person's chance in developing Alzheimer's disease or delay its onset while promoting healthy aging. These risk factors, these 10 risk factors, were the ones that were identified by our work group members in our ad hoc advisory council meeting as having evidence, as being impactful, and also being ripe for public health intervention. Next slide. This graphic shows us the different goals of the National Alzheimer's Project Act, the National Plan, the 2021 update. It shows us the 5 goals and the addition of the 6th goal that was added to the 2021 plan, which is accelerate action to promote healthy aging and reduce risk factors for Alzheimer's disease and prevention. This graphic shows us on the disease trajectory of Alzheimer's disease and related dementia where each of these risk factors lie. So in July of 2021, the Advisory Council unanimously supported the adding of a permanent risk reduction subcommittee to the advisory council, as well as a new goal 6. This is the first goal that was added to the plan since its formation in 2021. Our webinar today is going to explore the latest scientific advances on risk reduction and the importance of the inclusion of risk reduction as a national priority. Presenters will share actions that can be taken by public health professionals, healthcare providers, and community service organizations. The cross-cutting theme of social determinants of health will also be addressed in each of our presentations. Next slide, please. I have a group of amazing presenters that are going to speak to you today. Our first presenter is Dr. Tisa Marie Sherry. She's the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy within the Office of the Assistant Secretary for Planning and Evaluation, or ASPE, at the U.S. Department of Health and Human Services. Within her role at ASPE, Dr. Sherry's office oversees the implementation of the National Alzheimer's Project Act and coordinates policy development related to aging and dementia across HHS. Next slide, please. Our next speaker is Dr. Laura Baker. Dr. Baker is a professor of internal medicine, neurology, and public health sciences, and the associate director of the Wake Forest Alzheimer's Disease Research Center. Her work focuses on cognitive aging and non-pharmacological interventions to protect brain health and prevent cognitive decline, Alzheimer's disease, and other dementias. Currently, she is the PI or co-PI of 4 large national clinical studies that collectively have enrolled nearly 10,000 older adult participants. Next slide, please. Our third speaker is Mr. Matthew Baumgart. Mr. Baumgart is the Vice President of Health Policy for the Alzheimer's Association, leading a range of projects at the intersection of policy and programs. In this role, he heads the Public Health Center of Excellence on Dementia Risk Reduction, which is funded by the CDC. In addition, Mr. Baumgart leads the association's global policy efforts and works on the association's economic data and modeling projects. Prior to joining the association, he spent nearly 20 years working in the U.S. Senate. Our next speaker is Dr. Anne-Marie Navarre. She is a preventive cardiologist and associate professor of medicine in the Division of Cardiology at the University of Texas Southwestern Medical Center. Her research focuses on blood pressure and cholesterol lowering for cardiovascular disease prevention. She's a deputy editor at the JAMA Cardiology and a board member of the American Society of Preventive Cardiology. Next slide, please. Mr. Donald Smith, prior to joining Texas Healthy Aging at Home as CEO, he was employed as the executive director of the Tarrant County Area Agency on Aging at the United Way of Tarrant County in Fort Worth, Texas for over 15 years. He holds degrees in psychology, gerontology, and urban affairs, and has over 35 years experience working in health, human service, and governmental organizations in 4 area agencies on aging. Now, next slide, please. We will then follow with a Q&A section. Next slide. Here's a list of some resources, and I think many of our presenters have also a list of resources that they have included in their presentation. Next slide. So before we get started with our presentations, I want to thank the planning committee of this session, Dr. Helen Lamont, Dr. Joan Weiss, Dr. Nina Tomosa, and Aaron Long, as well as our colleagues from the National Institute on Aging, Elizabeth Pickett, Grayson Donnelly, and our amazing NIA technological support. I also want to thank Eva Jeffers, who's an ORISE Fellow at CDC, for her significant involvement in the development of Goal 6. So next slide, I'm going to turn it over to our next speaker, Dr. Tisa Marie Sherry.
Thank you so much, Dr. McGuire, and many thanks to all of you for having us here. As Dr. McGuire mentioned, I'm the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy in ASPE at HHS. It's my pleasure today to build on the wonderful background that Dr. McGuire shared about the 2021 National Plan to Address Alzheimer's Disease and our new risk reduction goal. Oops, so sorry, I advanced a little bit quickly. Okay. So the National Plan to Address Alzheimer's Disease was established by the National Alzheimer's Project Act, or NAPA, which was passed in 2011. The National Plan describes the work that is undertaken by HHS agencies and select federal partners, including the Department of Defense, the Department of Veterans Affairs, and the National Science Foundation, to advance research, public understanding, and effective clinical interventions and other services and supports targeting Alzheimer's disease and related dementias. NAPA also established an advisory council to review and comment on the national plan and its implementation, and to make annual recommendations to the Secretary of Health and Human Services and to Congress on priority actions. Importantly, the advisory council includes both federal and public members to ensure that the national plan is informed by broad stakeholder perspectives. When it was established, as Dr. McGuire mentioned, the plan had 5 ambitious goals. Goal 1 includes strategies to identify and expand research on Alzheimer's disease. Goal 2 includes strategies to improve clinical care. Goal 3 includes strategies to expand and strengthen long-term care and caregiving for people with Alzheimer's disease. Goal 4 includes strategies to educate the public about Alzheimer's disease, and Goal 5 includes strategies to enhance the federal government's ability to track progress on the national plan. In 2020, however, the Advisory Council began to consider the possibility of a 6th goal focused on dementia risk reduction. Why consider a risk reduction goal? Well, while we have not yet identified effective interventions to prevent people from getting dementia altogether, we've been learning more and more about risk factors for dementia and ways to reduce the chances of developing this disease by addressing risk factors. In particular, there's growing evidence that effectively managing hypertension and being more physically and cognitively active may reduce the risk of developing dementia. And there are more studies underway to investigate how our risk of dementia changes when we address other risk factors for the disease like diabetes, inadequate sleep, poor nutrition, depression, substance use disorders, hearing difficulties, and poor dental health. In fall of 2021, as Dr. McGuire mentioned, based on the growing research literature on risk reduction, the Advisory Council agreed that there was enough positive evidence to warrant broader, more deliberate efforts by HHS to address risk factors for dementia. So in December, HHS added a 6th goal to the national plan to accelerate action and promote healthy aging to reduce risk factors for Alzheimer's disease and related dementias. As this diagram from the national plan shows, compared to previous goals, the new goal primarily targets individuals who do not yet have any symptoms of dementia, but may be at elevated risk. Evidence on risk factors for Alzheimer's disease is growing and still evolving, as is evidence on the impacts of interventions that target risk factors. Still, the Department of Health and Human Services decided to add this new goal for several reasons. First, healthy aging is a key priority for the department, and addressing the risk factors for dementia aligns with promoting brain health and healthier aging overall. There are also no apparent downsides to addressing risk factors by identifying and managing chronic conditions or promoting improved nutrition and increased physical activity. These are things that we would want to do anyways. Second, as the evidence base on risk reduction grows, we want to be able to translate our findings into effective risk reduction interventions as quickly as possible. Through this new goal, we will build the infrastructure we need to identify and research risk reduction interventions, and then to translate those interventions into healthcare and public health practices as quickly as possible. The third reason relates to achieving health equity, which is among HHS's highest priorities. The chance of developing Alzheimer's disease and related dementias is not equal. Black and Latino Americans are more likely to develop the condition, as are women and people with certain types of chronic diseases, and these disparities are projected to widen over time. There's also evidence that communities of color experience inequities at every stage of dementia care. Black, Latino, and Native American populations are less likely to receive a timely diagnosis of dementia, less likely to receive evidence-based treatment, and have more difficulty accessing long-term care and supports. As a result, equity in addressing interrelated social determinants of health are core principles of the national plan and have long been reflected in activities under all of the plan's goals. But in order to comprehensively address inequities in dementia, and in particular, the burden placed on Black, Latino, and Native American communities, we have to also address the risk factors that lead to a higher prevalence of dementia in these communities in the first place. And that's another reason why HHS felt it was important to include this new goal on risk reduction and to explicitly emphasize eliminating disparities in risk factors. Black, Latino, and Native American populations currently experience a higher burden of risk factors for dementia and greater difficulties in accessing healthcare to address these risk factors. These differences in the burden of risk factors contribute to differences in the incidence of dementia in these communities. Fourth and finally, HHS recognizes that many of these risk factors are either caused by or exacerbated by systemic community and structural inequities. So this new sixth goal provides an opportunity to address not just what individuals can do to protect their brain health, but also to create communities and institutions that support healthy aging for everyone and that make it easier for people to make these changes. These principles are reflected in each of the strategies under our new risk reduction goal. Strategy 6A will support research that will enhance our understanding of dementia risk factors and the impacts of interventions that address risk factors. Strategy 6B will rapidly translate research findings into clinical practice, Strategy 6C into public health action, and Strategy 6D into interventions through the Aging Network. Strategy 6E will address inequities in risk factors. And finally, through Strategy 6F, we will work to educate and engage the public at large about ways to reduce risk factors for Alzheimer's disease and related dementias. I'll share some examples to give you just a flavor of some of the concrete action steps that HHS is currently pursuing under the new risk reduction goal. Under Strategy 6A, to expand research on risk factors, the National Institute on Aging and the National Institute on Neurologic Diseases and Stroke are supporting a number of studies that examine differences in the prevalence of dementia risk factors across different racial and ethnic groups and the impacts these differences have on disparities in Alzheimer's disease and related dementias in these populations. Under Strategy 6B, to translate research findings into clinical practice, HRSA is using its geriatrics workforce education program to disseminate curricula to train the healthcare workforce in addressing brain health, and CDC has supported the American College of Preventive Medicine to develop a brain health continuing education and resource website to increase healthcare providers' awareness of brain health. Under Strategy 6C, to translate research findings into public health practice, CDC is convening a national summit on risk reduction this year. Under Strategy 6D, to translate research findings into interventions through the Aging Network, the Administration on Community Living is delivering health and wellness programs to older adults through their Capacity Building and Sustainable Systems Initiative, with a special focus on reaching historically underserved communities. And under Strategy 6F, to engage the public on risk reduction, the National Institute on Neurologic Diseases and Stroke, through its Mind Your Risks campaign, and CDC through its Million Hearts Initiative, both support public awareness campaigns to educate people about the link between high blood pressure and dementia risk. For our next steps, first, we are committed to successfully implementing all of the risk reduction action steps identified in the 2021 plan update. At the same time, we view these action steps as the beginning of our efforts on risk reduction. Our work is not done. So to build on and improve this work, through the Risk Reduction Subcommittee of the Advisory Council on Alzheimer's Research, Care, and Services, we will identify additional opportunities to advance this important agenda. This will include connecting with broader health promotion and disease prevention efforts with relevance to brain health to ensure that we're working collaboratively and synergistically to support healthy aging. And as discussed earlier, we want to continue to focus on community risk reduction and supporting interventions that help individuals to make healthy changes rather than placing the onus entirely on them, particularly in a health and social services system that can be very challenging to navigate. Finally, we want this to be a truly national plan, not just a federal plan. So we're eager to engage with state and local governments and non-governmental organizations to understand how we can work together to implement and strengthen the national plan. I want to recognize my ASPE colleagues who have been coordinating all of this work, in particular, Lauren Anderson, Emma Nye, Gavin Kennedy, and Bill Martin, and especially Dr. Helen Lamont for her leadership. I also want to thank our federal partners who are doing the actual work of implementing this really ambitious strategy. And last but not least, I want to thank Secretary Becerra for his support of this initiative together with the rest of our HHS leadership. As a couple of resources for more information, I have included here a link to the national plan itself in the 2021 update, as well as a recording of a stakeholder briefing that we did, which engaged a number of our partners who are implementing this plan. We believe this new goal represents an important step toward improving health outcomes for older Americans, and we're very excited to work with all of you to implement this bold vision for healthy aging and brain health. Thank you.
All right, we will turn it over to Dr. Baker.
Okay, thank you everyone for taking your time today to join us. My job is to kind of take you through what it might mean to look at a particular risk, a particular element of that we could change, where we can modify risk, and kind of talk to you about what are the steps from the very beginning to identifying a risk modifier all the way to the end of pushing it out and hopefully changing policy down the road. And so my particular area right now that I'm going to focus on is exercise. So first of all, what we're going to do is I'm just going to talk to you a little bit about how exercise, and physical activity in particular, is gaining momentum as a therapeutic strategy to protect brain health and reduce the risk for cognitive decline and dementia. I'm also going to share some research resources that are available to test whether exercise might be a potent risk reducer for dementia. And, and to describe some evidence showing that exercise might indeed serve as medicine, could be medicine. And what are our obstacles so far in making more progress? And then lastly, going forward, what are the action items needed to develop a sustainable and accessible intervention program? So as Tisa has described a moment ago, our new goal for the national plan is to accelerate action to promote healthy aging and reduce risk factors for Alzheimer's disease and related dementias. And the goal is to reduce prevalence of modifiable risks by 15% by 2030, which would have a tremendous impact on disease onset and progression. So here are the kinds of risk factors that we are targeting here, and this is in line with global initiatives as well, like, for example, from the World Health Organization. We are all on the same page about which risk factors we need to target. Next slide, please. Okay, so resources that are available right now through the government, through NIH. You can see, I'm going to focus my talk right now on non-pharmacologic interventions, those interventions that are focused on reducing risk, modifiable risks. And you can see that right now, the number of grants, NIH grants that are available to study non-pharmacological interventions is greater than those grants that are earmarked for early stage clinical drug development, late-stage clinical drug development. And actually, it's in line with preclinical drug development. So non-pharmacological interventions that will help us identify those risks that can be modified, effectively modified. We do have the resources to do this through NIH. Next. And I wanted to show that since 2009 to 2019, just wanted to show you how this has changed. The number of grants focused on these modifiable risk factors has changed over time. Next. Within the non-pharmacologic interventions, you can I'm showing a pie chart here, dividing out the different kinds of grants that are available. So there's the blue is a large section devoted to physical activity and exercise. And there's another, that green, I'll just bring your attention to that, is a combination therapy. That's where the field has kind of moved into combining what are the benefits on brain if we change your physical activity, if we change your diet, if we change your cognitive activity, your social engagement. That's really a hot topic right now. Next, please. All right, so one action described that we want to accomplish with Goal 6 is to educate the public and healthcare workforce about risk reduction. So we've got to do this. We've got to start, and the messaging has to be intense. It has to be ubiquitous. So in 2019, the Wall Street Journal published this particular, this is a front page feature article all about what is science telling us about preventing dementia, where these particular modifiable risks were listed. It was a beautiful article, but I thought it was a milestone because we had not yet seen in the public domain an article with this kind of a focus on lifestyle modification as a mechanism to protect brain health. Okay, next. And the Lancet Commission, that's good. Lancet Commission in 2020 published their recommendations. According to the Lancet, up to 35% of all dementia cases could be prevented by tackling these risk factors, and that we really need longer-term lifestyle intervention trials to answer this question. More recently, the CDC and the American College of Preventive Medicine had another publication that was called Promoting Healthy Lifestyles and Blood Pressure Control, and it describes how healthy choices can reduce risk of cognitive decline. This article has been, and other resources have been widely disseminated. So this we need to get the message out into the community that physical activity, for example, can help reduce risk of cognitive decline. Next, please. Okay, I'm going to ask you to take the control again. This is not, so next slide, please. Okay, thank you. So exercise is my focus just for a moment as an example. We know that exercise is a potent anti-aging mechanism. That exercise reduces stress and improves mood. It improves cardiovascular function. It improves the health of the vessels, both in the body and in the brain. It reduces your risk of type 2 diabetes. It reduces your obesity. It touches all of these diseases that naturally, at least in our culture, do increase in prevalence with advancing age. In the last 15 years, we're also learning that exercise also has a protection for brain health and may in fact help prevent or slow or prevent cognitive decline associated with Alzheimer's disease and related dementias. Next, please. All right, and this busy slide is only to show you that this is what we have to go through. When we're trying to identify a risk reduction strategy, the science has to be strong. We have to know that this is a viable candidate in order for us to invest our resources, both in terms of rolling this out, not only in science, but also for changing public health policy. So exercise has multiple mechanisms of restoration for the body and the brain. It improves brain cell health. It reduces oxidative stress, improves glucose metabolism, and so forth. There's a lot of evidence to suggest exercise is a prime candidate for reversing aging effects on the body, but also slowing cognitive decline. Next. I just want to show you three different examples of 3 studies just to make my point here. This is a study showing some brain images of older adults. These are cognitively normal older adults. And this is a 6 months of aerobic exercise intervention versus a stretching and balance control. And what you're seeing in the colored areas, in the blue areas and the orange yellows, are areas where brain volume was increased with 6 months of exercise. This is no medications on board. Next. And so that was in cognitively normal folks, but since then, we have also shown that there are benefits with exercise for people with mild cognitive impairment, that is in the earliest stages of Alzheimer's disease. Next. Here's another example. This is one of our studies. We showed that with 6 months of aerobic exercise in people with mild cognitive impairment, that is an early stage of Alzheimer's disease, we saw changes in their whole brain blood flow, the blood flow to the whole brain. Next. And we also saw, importantly, changes in specific areas that are associated with aging. These are the red areas. These are areas that naturally decrease blood flow with advancing age, but also in areas that not unnaturally, that decrease blood flow with Alzheimer's disease. That's in the blue area. So 6 months of exercise increased blood flow in these critical areas that have to do with aging and Alzheimer's disease. Okay, next. So is it worth the trouble? Next. So what I'm showing you here is a summary of several different studies that have been conducted since 2010. So quite some for the last 12 years. The line down the center kind of divides studies that indicate that it's not effective, it favors control, versus the results favor the benefits of exercise. And all of the spokes that you see on the right side of the line favoring exercise gives you the overall impression that the majority of studies that have been reviewed in the last 12 years all favor the benefits of exercise on cognition for people with mild cognitive impairment. Next. All right, so in order for us to evaluate, is this a viable risk reduction strategy? We have to really piece apart, we have to dive in and take a look at exercise to find out what about it could be risk reducing. Next. So one part that we have learned from our science is that exercise intensity matters. As with any medication, if the dose is too low, you cannot expect the same benefit. So when we're thinking about rolling out a program for risk reduction, we have to pay attention to intensity. Next. We also know that the duration matters. If one of the goals of risk reduction is to restore health to the body, in order to restore health to the brain, it cannot happen overnight. It takes time to restore this type of health. So short durations of exercise, a couple of months, is not sufficient to provide protection against risk. Next. The level we've learned from all of our studies that support matters. You can't just go to your doctor's offices and say, and have the doctor say, you need to start exercising. This is not helpful. This will not succeed in a population who is not used to doing exercise. So if we're going to succeed in this program, we have to provide support. Now, some of our studies that we've completed so far have shown with adequate support, we can get people to stay in the study and keep exercising at the prescribed dose. Next. And we also know that resources matter. The quality of the neighborhood facilities, the public messaging. How much time does a person have to exercise? Are they busy doing caretaking so they don't have the sufficient time to go take care of themselves? Are there transportation issues? Are there cost issues? So the health equity or health disparities really come to play when we're trying to roll out a program that's equal to all when there are unequal barriers. Next. So I just wanted to show you, and you can go ahead and click on a couple. And one more. Okay, and one more. Okay, so I want to just give an example of one study that's trying to meet all of those different questions that I presented in the previous page. The excerpt trial is one we've just finished. It's a national trial. We're working with another community partner, which is key for the success of Goal 6. We are working with the YMCAs. They have been at the table since day one. We know that if we are successful, it's the YMCA that's going to have to roll out this program, or someone like the YMCA, not an academic hospital. So this partnership has been key. We engage the communities. That's also part of our goal for part of our charge for Goal 6 is to work within communities to heal a whole community. And so in this study, we have gone out in the community and worked with the community to recruit participants into the study and find community resources that they could use to complete their physical activity. We're going to report the top line results this summer. And next. So future directions for sustainability. This is our next step. We've got the science to say it could be a risk reduction. So how do we roll this out so that it could be a viable, sustainable intervention to reduce risk for all people? So if you could just click around here, 4 clicks. Yeah. So what you can see here is we have needs. In order to build a community program, we have to have ready access to facilities. We have to have ubiquitous messaging, encouraging physical activity. Basically, we have to create a movement where this is the standard. This has been done in other countries, Norway, for example, and China, where exercise facilities are well funded and available within the community. It changes how people behave. We have to have low or no cost access. We need adequate resources, support for these individuals. You need coaching support, and that's what we've learned over and over, lifestyle coaching kind of support. We need partnerships with community organizations. We need healthcare to weigh in and be part of this program where a prescription is provided with referrals to a program, and also other logistic support like transportation, community and family support. And also it has to continue to be evidence-based. And so that's the importance of the science and all that NIH has provided to provide the resources for us to continue these investigations. And my last slide, please. So how do we transition from this science to policy? And this is what we're working on. So it's a work in progress, but it's imperative that we need robust results from science, from rigorous trials to motivate action. We need incentives for healthcare to promote exercise as medicine programs. We need patient incentives to participate, and we need community-based infrastructure that's equal. There's equity for all communities. That these need to, when we roll them out, one neighborhood cannot be. It has to be equal access for all neighborhoods. Otherwise, this program is not going to address our health equity priorities. Okay, thank you.
Thank you so much. And next we'll hear from Matthew Baumgart from the Alzheimer's Association.
Thank you very much, Lisa. Hello, everybody. Glad to be with you today. So as the science on dementia risk factors increases and as our understanding grows, it is really right for public health to take action to address risk factors from a community perspective. That's part of what the new Goal 6 includes, and that is really where the Public Health Center of Excellence comes in and what I'm going to talk to you about today. Next slide. Before I get to the Center of Excellence, I just kind of want to talk to you about briefly about how we got here. Many of you are aware of the BOLD Act, but just to review it for those who are not familiar. Next slide. So in 2018, Congress passed the Building Our Largest Dementia Infrastructure for Alzheimer's Act, or the BOLD Act, to expand the nation's public health infrastructure to address Alzheimer's and to increase the capacity of public health to address Alzheimer's disease. There are 3 main components of the legislation. The first is to establish centers of excellence. Second is to provide grants to state, local, and tribal public health agencies across the country. And the third is to increase data analysis and timely reporting. Next slide. And in 2020, after Congress passed and then subsequently funded the BOLD Act, CDC funded 3 centers of excellence, including the Dementia Risk Reduction Center at the Alzheimer's Association. The other 2 centers focus on caregiving, that's out of the University of Minnesota, and the third is on early detection and diagnosis out of New York University. Next slide. So let me illustrate why the Risk Reduction Center is really important and why addressing at this particular time dementia risk factors is so important from a population level perspective. Next slide. Many of you have seen these statistics before, but currently there are more than 6 million older adults in the United States living with Alzheimer's dementia. And with the aging of the population, that is projected to increase to nearly 14 million in 2060. Next slide. And looking at what I call the big five risk factors, these are risk factors that are commonly cited as risk factors for cognitive decline and dementia. They are also have some of the strongest evidence behind them. But you can see the prevalence of these risk factors among the U.S. population. The hypertension among those in middle-aged is over 40%. Obesity is nearly 40%. Physical inactivity, you just heard Laura talking about that. That's well over 40%, closing in on half of the adult population who do not meet physical activity guidelines. Next slide. And when you look across all five of these, over 63% of adults in the United States have one or more of these risk factors for dementia, and more than 2/3 of Blacks, Hispanics, and Native Americans have at least one of these five risk factors. Next slide. So according to the Lancet Commission, as many as 40% of dementia cases worldwide might be attributable to 12 suspected risk factors. They looked at more than the five I showed on the previous screen. But looking at the 12 that were cited by the Lancet Commission, they indicated that worldwide as many as 4 in 10 dementia cases could be attributable to those 12 risk factors. Given that, and given the high prevalence rates of some of these risk factors, as I showed you on the previous slide, there is a great opportunity for public health to act. And there is a possibility for a significant impact with an aggressive action. I put on this screen 3 population attributable risk analyses. 2 of them were unpublished, but one was published in Lancet Neurology back in 2014 that looked at what would happen if you could aggressively address risk factors, and aggressively was either a 10% or 15% per decade improvement in the big five, as I call them, or in the case of the Lancet Neurology article, the big five plus depression and education. And you can see there that with an aggressive effort to improve the prevalence of the risk factors, it could result in as many as 1 million or more fewer cases of Alzheimer's dementia in 2050. Next slide. So this is really where the Center of Excellence comes in. Next slide. So the Centers of Excellence, as I mentioned, there are 3 of them, are really designed to give public health agencies at the state, local, and tribal level the tools and resources needed to act in their communities. And for the Center of Excellence on Risk Reduction, I have put on this slide kind of our general workflow. Part of our task is understanding the science and helping public health agencies and the public in general understand the current state of the science, then identifying what can be done about it from a public health perspective, building those tools and resources for public health, and then really helping to drive action by public health agencies. Now, I've shown these in a linear format because my brain anyway works very sequentially and very linearly, but there are activities on all of these steps or many of these steps going on at the same time. And that's what I want to share with you now, some of the things that the Bold Center, Public Health Center of Excellence on Risk Reduction has been doing. Next slide. So we spent a good chunk of last year working with our academic and scientific partner, Wake Forest School of Medicine, Jeff Williamson, leading the effort there. Laura Baker, who you just heard from, was a member of the research roundtable that Jeff put together. And they led a review and synthesis of the state of the evidence on modifiable risk factors for cognitive decline and dementia. We have published short 1 to 2 page summaries on 11 of these risk factors. They talk about the current state of the science as well as some of the public health implications for those risk factors. You can download those, read those on our website at alz.org/publichealth. Next slide. Following this review and synthesis of the evidence, last August we held our first public health roundtable with public health academics and on-the-ground public health officials to begin identifying and prioritizing public health actions to address these risk factors. And following that, we have begun to prepare toolkits and other resources on how public health can address the risk factors at the community level, and we're also analyzing state and local level data on various risk factors. And the local level data is particularly intriguing and helpful because it will identify for state public health officials and local public health officials where the particular hotspots may be for the various risk factors. Now, for many public health agencies, even if COVID were not a factor, the capacity to take on this issue is very, very limited. A lot of public health agencies are very small and don't have a lot of funding. And so in recognition of this, one of the activities that we're doing as the Bold Center is working with public health agencies on what we call community convenings. It's to use the public health convener role to bring the community stakeholders and community actors together in a very structured three-step process in which they decide how collectively as a community they can address dementia risk factors. That takes some of the load off of public health, but still helps to drive action to improve the prevalence of the risk factors. Next slide. We at the center have also published suggestions on risk reduction recommendations that can be included in state and local Alzheimer's plans. We've seen over the last decade, as all but one state has published a state Alzheimer's plan, that these plans can really help drive action. And so if we're going to address risk reduction, and if states are going to address risk reduction, it's really important that they're included in states' plans as they're written and as they're updated. And so we published a document on things that could be included in those plans to help drive action. And we're now circling back to the beginning of our linear spread, back to the research roundtable. We're now again working with our partners at Wake Forest to do a review and synthesis of the evidence on social determinants of health related to dementia. And that's from two different perspectives. First, what are the social determinants of health that may in and of themselves be risk factors for dementia? For example, poverty, the quality of early childhood education or air pollution, and to look at social determinants of health that are barriers to addressing some of the modifiable risk factors for dementia. For example, continuing on the theme of physical activity, encouraging physical activity to help reduce the risk is a great goal, but it's difficult if people don't live in a safe neighborhood, if there aren't nearby parks, if people can't afford gym memberships. So what are the social determinants of health that play a role in addressing dementia risk? So next slide. So that's kind of bringing you up to date on where we have been in the past almost 18 months as the Risk Reduction Center of Excellence. But here's some of the other activities that we have in the pipeline coming up. Building on the review and synthesis of the evidence on social determinants of health, we'll be holding a workshop at the Alzheimer's Association International Conference in San Diego this summer to review the science and to begin translating that to public health action. We'll be bringing together both dementia researchers and the public health community to have this conversation. This is an open meeting. You don't need to attend the AAIC itself to attend the workshop. So more information on that will be coming, but save the date if you're interested in that. Following that workshop, we'll be having our second annual Public Health Roundtable to begin identifying and prioritizing what public health can do on social determinants of health. We're also working on putting together a Dementia Risk Reduction Summit in Atlanta, working closely with our partners and funders at CDC. This is broadly to increase understanding of dementia risk factors and then really to promote the translation of science into public health action. And the other thing we've begun working on is the development and testing of risk reduction messaging that can be used from a public health perspective to reach the public. Next slide. And finally, some highlights of some of our future activities down the road. They're not quite yet in the pipeline, but we are planning them down the road. One is regional learning collaboratives. This is something we found does not work well over Zoom. And so with hopefully as we come out of COVID, we'll be able to move forward on regional learning collaboratives to bring together some state, local, and tribal public health officials to increase their understanding about dementia risk factors and to work with them to develop work plans for their communities. We're also going to be working in the future to develop tools for public health agencies to work with local health systems to address dementia risk factors. We realize that health systems, whether that's an HMO or a hospital system or a large physician practice, they are really key in the long term to addressing dementia risk factors. And so we'll be developing tools for how public health can work with these health systems to collectively partner to address the risk factors. And we'll be working to expand partnerships with organizations involved in the risk factors, both at the national level and working with local public health agencies on how they can expand partnerships in their communities. Next slide. Please feel free to reach out to us with any questions that you might have. Happy to talk to any of you. We can be reached at centerofexcellence@alz.org. That's our email address. And feel free to go to our website, alz.org, public health. There's a lot of public health materials broadly on the Alzheimer's issue, but there's also specific information on risk reduction and risk factors, including some of the materials I mentioned to you previously. Lisa?
Great, thank you so much. And we will turn it over to Dr. Novarka.
Thank you so much. I'm Anne-Marie Navarre. I'm a preventive cardiologist at the University of Texas Southwestern Medical Center. And today I'm going to be talking about some ways that we can both lower risk of dementia and lower the risk of heart disease and stroke. There's a lot of overlap between what I do in clinic and what we're able to do for dementia reduction as well. These are my disclosures. Just wanted to pause and note that I do receive both research and consulting fees from a number of companies who make therapies in these areas. I want to be transparent about that. So this slide comes from somebody referenced earlier, the 2020 Lancet Commission that looked at risk factors for dementia. And we see, a lot of these risk factors are also actually risk factors for heart disease. Before we drill into that, I just have to pause and, as a general physician, point out one of the challenges for one of these risk factors, which is actually quite easy to treat from a medical standpoint, but very hard to treat from a policy standpoint, and that's hearing impairment. We know from a number of studies that people with hearing impairment, particularly those without access to hearing aids or assistive devices, are at increased risk of dementia. But unfortunately, current Medicare and Medicaid insurance policies don't cover hearing aids. There is ongoing efforts in Congress to move forward legislation in this area, but it's yet to pass. So it's frustrating as a clinician that some of these risk factors are actually potentially modifiable, but we face barriers on reimbursement and cost rather than barriers on the actual science. Now, that aside, I'm a preventive cardiologist, and I spend a lot of time thinking about ways to prevent cardiovascular disease, including heart failure, coronary disease, heart attacks, and stroke. And the nice thing when we're thinking about how to prevent dementia is that out of these 12 risk factors, 10 of them are actually strongly associated with heart disease as well. And those 10 risk factors are listed here on the slide. So while we still have a number of research needs in terms of understanding how to modify these different risk factors and the degree to which modifying these risk factors can improve cognition and cognitive function over time, we have really strong evidence while we're waiting for that there's significant benefits in terms of cardiovascular disease protection to modifying these risk factors early and sustained over the life course. Today, we're going to talk about 5 of these. And these are risk factors that I picked because they're ones that we commonly address in clinic. And there are risk factors that people who are interested in lowering both the risk of heart disease and their dementia can work with their healthcare provider to receive medication and other behavioral support to help address these risk factors. We're going to start with 2, smoking and obesity. And I think it's important first to point out from a physician standpoint that these are risk factors that we need to be considering medical conditions and that are medically treatable. There's a lot of stigma around both obesity and smoking as if it's a lifestyle problem. And while lifestyle modifications are critical to combating both obesity and smoking, there are a number of ways that patients can work with their healthcare providers for medical support in these interventions. For obesity, we know that healthy diet, irrespective of weight loss, can lower the risk of cardiovascular disease. And referrals to nutritionists and registered dietitians are critical ways to engage our colleagues who can help guide our patients to changes in their diet to both help weight loss, but more importantly, heart healthy foods to help promote cardiovascular health over the lifespan. For people with severe obesity, bariatric surgery has not only shown to lead to weight loss, but in fact lowers the complications of obesity like hypertension and diabetes and lowers the risk of long-term cardiovascular disease. And finally, it's a really exciting area for the medical treatment of obesity, as we have a number of FDA-approved medications now to treat diabetes that also have shown weight loss. One of these classes of medications is the GLP-1 receptor agonist class. And one of those, semaglutide, at higher doses, is actually now approved for weight loss. So we have now a medication that can help lower cardiovascular disease risk and treat obesity at the same time. Obviously, we have challenges in both utilization of these medications. They often are expensive, and we're going to need to pay close attention to the out-of-pocket costs for our patients for these therapies and work to promote fair pricing of medications to ensure equitable access for all. Smoking is another medical problem that we can treat or we can help support our patients with both FDA-approved medications as well as proven effects of behavioral counseling. Numerous studies have shown that medication or pharmacotherapy to treat smoking works better when paired with referral to behavioral counseling. And everybody in the United States has access to either a phone-based or web-based behavioral health support for smoking cessation through the Quitline or smokefree.gov. These sites also have references for other languages, so it's not just for those who speak English. We also know, though, that medication therapy, including nicotine replacement therapy, varenicline, which is also known as Chantix, and bupropion, which is also known as Wellbutrin, have been shown to help people abstain from smoking who seek to quit. The challenge is that providers don't always recommend them for patients who seek to quit smoking. So we need to do a better job on our end as healthcare providers in learning about utilization of these therapies, identifying patients who may benefit from them, and then helping provide access to these therapies for our patients as they seek to quit cigarette smoking and use of other tobacco products. We already heard a great talk from Dr. Baker about physical activity, telling us the important links between movement, exercise, and promoting long-term brain health. I want to point out one thing from a physician standpoint that I think is helpful for patients as they think about how they can increase their physical activity. It can be daunting to go from no physical activity to having to run a marathon, but that's not what we're asking people to do. In fact, although Dr. Baker does emphasize the importance of sustained fitness over your lifespan, in fact, even small increases in the amount of regular physical activity have been shown to lower the risk of Alzheimer's disease as well as cognitive impairment compared to no activity. In fact, even moderate activity defined as walking intensity activity 3 or more times a week in women was shown over the age of 65 was shown to lower the risk of cognitive impairment by almost 50%. So for those of you who may be overwhelmed or feel like you can't reach the minimum recommended physical activity targets, however close you can get there, even incremental increases in sustained physical activity over years is likely to decrease long-term risk of dementia and cognitive impairment. We also know that physical activity is a key way to help prevent cardiovascular disease, including heart attack and stroke. These are the recommendations from the American Heart Association for physical activity in adults. And the recommendations are 150 minutes a week of moderate intensity activity, or 75 minutes a week of high intensity activity. And the easiest way that I talk to my patients about how to know if what you're doing is moderate or vigorous activity. With moderate intensity activity, you should be working hard enough that you can speak in complete sentences, but you couldn't sing a song because you're too winded. High intensity activity is something like running or singles tennis, where you can speak, but only in very short sentences because you're trying to catch your breath. We also recommend at the Heart Association at least 2 days a week of strength training for muscle building, because that can promote additional metabolic stability and decrease further risk of heart disease and heart disease risk factors like diabetes. Blood pressure is a key modifiable risk factor for dementia and cardiovascular disease. One of the best studies showing the importance of sustained control of blood pressure over time comes from Framingham cohort study. This took people in the 1970s and has followed them for decades to look at how risk factors in the middle of your life impact your long-term risk of things like dementia and cardiovascular disease. In this particular study, people were followed for several decades and were found that, and they found that for every 10-point increase in your systolic blood pressure in midlife, your long-term risk of dementia was increased by 20%, really emphasizing the importance of thinking early about modifying risk factors to help promote long-term brain health. Now, what do we know about blood pressure and dementia from clinical trials? This meta-analysis published in JAMA last year took 14 different randomized trials where people were randomized to different blood pressure therapies and pooled all the data together for almost 100,000 patients. The follow-up time for this was about 4 years, and pooled together, the authors found a small but real decrease in the risk of dementia as well as cognitive decline in the groups of people who were randomized to blood pressure lowering compared to the people who were not. Now you might ask, this looks really small compared to the data you just showed me on the last slide. And I'll point out that most of these trials don't follow people for a very long time. We're looking at the benefit of blood pressure lowering at about 4 years on average for these studies. And we know that the biology of dementia is something that it takes a long time to accumulate risk and a long time to start to accumulate risk, which means we have a long time to actually accumulate benefit. So when I look at these data in context with the observational data from Framingham, it really emphasizes the importance of not waiting later in life for blood pressure control to maximize the potential benefits of blood pressure lowering on overall risk of dementia and cognitive decline. The SPRINT randomized trial gave additional information for us about what the optimal blood pressure should be to help prevent dementia and promote long-term brain health. This study was actually designed to show whether or not a lower target blood pressure, in this case a systolic blood pressure less than 120, was better than a target systolic blood pressure less than 140. And in the overall study, we saw dramatic decreases in the rates of stroke and heart attack in people randomized to the lower versus the higher blood pressure arm. But in follow-up, a subset of people also had cognitive assessments. And what we found is a 17% decrease in the risk of dementia, as well as a 19% decrease in the risk of mild cognitive impairment in those randomized to the intensive versus the standard control arm. There's an important asterisk here, which is that probably due to sample size, this relative risk reduction was not statistically significant. But combined with what we know about from observational studies about the risk of hypertension and dementia risk, it's biologically plausible that lowering blood pressure to a lower goal will help promote prevention of diabetes and cognitive impairment over time. Diabetes is another risk factor that we can treat medically to help prevent risk of dementia. This graph comes from a nice review article of the of diabetes and how it interplays with the risk of dementia, both through promoting atherosclerosis, microvascular disease, direct toxicity in the brain, and insulin. And we know that duration of diabetes, having uncontrolled diabetes, hypoglycemia, all increase the risk of dementia. Also, all of these things increase the risk of myocardial infarction and stroke over time. And in the last several years, we've had 2 different classes of therapies that are absolutely breakthrough treatments to help us lower the risk of cardiovascular disease in persons with diabetes. These include the class of medications called SGLT2 inhibitors and GLP-1 receptor agonists, which not only lower glucose or improve blood pressure or blood glucose control in people with diabetes, they've been shown to decrease the risk of heart attack, stroke, heart failure, and cardiovascular death. As such, the American Diabetes Association now recommends that all persons with diabetes, type 2 diabetes, who are at risk for cardiovascular disease or have established cardiovascular disease, use these agents as first line after metformin to help further promote cardiovascular health. We don't know if these will decrease the risk of dementia, but we do know that by preventing strokes, we can promote long-term brain health. Speaking of, I would be remiss as a cardiologist to not talk about stroke and stroke prevention as part of a broader conversation about preserving functional status and brain health over time. And I'll point out 2 important risk factors that are really key to help preventing stroke over the life course. The first is treatment of LDL cholesterol. We know from clinical trials of tens of thousands of people that lowering your LDL cholesterol with statin therapy can decrease not only your risk of heart attack and heart disease, but also your risk of stroke. In fact, statins have been shown to lower the risk of stroke by 17% when compared to a placebo. The other type of stroke that we can prevent are strokes that are caused from the heart rhythm problem, atrial fibrillation. Atrial fibrillation leads to blood clots that form in the heart that when they break free can go to the brain and cause stroke. And although we have a number of different therapies to prevent stroke in people with atrial fibrillation, including warfarin and novel anticoagulants like rivaroxaban and apixaban. Rivaroxaban, by note, is actually going generic soon. We still find that 1 in 3 people with atrial fibrillation at high risk for stroke are not on a blood thinner. This is a massively important opportunity for us to decrease the risk of stroke through increased utilization of anticoagulation therapies in people with atrial fibrillation. Also, we have new technologies that are helping us better identify people with atrial fibrillation for treatment before they present with stroke in the first place. This includes AFib detection technologies that have been shown to be accurate in both the Apple iWatch as well as the Fitbit. I think the next era of AFib is going to really move to increased detection of atrial fibrillation and improve population health work towards increasing utilization of anticoagulation to help prevent strokes in this population. And so when I see patients in clinic who are worried about dementia risk, I talk to them about the modifiable risk factors, but I also make sure that that's part of a broader conversation around preventing stroke and promoting overall brain health. And with that, I thank you for your time.
Thank you very much, Dr. Navar. Next, we'll have Don, our final speaker of the day.
Thanks. Let me begin by saying I am extremely grateful to the staff at the Area Agency on Aging of Tarrant County here in Fort Worth and our many other partners who made the work I'll be talking about possible over the past 15 years. Next slide. Area agencies on aging were created by the Older Americans Act in 1973, and for most of their 49-year history, AAAs have been required to target services to high-risk populations. I'm going to be sharing those provisions with you from the Act, talk about some of the targeted programming we've done here in Tarrant County, a couple of our ACL-funded dementia-capable projects, and also services to address social determinants of health and some of the barriers that we have faced in providing community-based services and supports. Next slide. These are the targeting provisions. included in the Older Americans Act. They have remained relatively the same for about 40 years. In the 90s, there was a little bit more emphasis added on low-income minority individuals, and also in the 2000 amendments targeting to people residing in rural areas. In Texas, we're particularly concerned about number 6 because according to CMS, we have more low-performing one-star nursing homes than any other state in the country. Next slide. So one of my favorite ways to approach any conversation about health disparities is by looking at zip code data. For example, we have a zip code here in Tarrant County with a life expectancy of 66.7 years. And what you'll find in that zip code and similar zip codes are high rates of heart disease, hypertension, diabetes, dementia. There are also high crime neighborhoods, big food deserts with not a lot of access to healthy food, and also one risk factor I haven't heard mentioned today, and that's a much higher average number of adverse childhood experiences, which are associated with a lot of the other risk factors that we've discussed. My favorite out of all the outreach strategies as far as being the most effective is door-to-door strategies. These are very low-cost strategies for reaching people and reaching unserved and underserved populations. Next slide. So we started using geographic information systems to target services in low-income areas with high concentrations of people living alone to address loneliness in 2006. In 2008, we replicated a dementia care transitions program that was developed by Baylor, Scott & White in Central Texas. And then United Way funded a 9-year Healthy Aging and Independent Living initiative that included both programs for caregivers as well as wellness programs. We served over 63,000 people, and there's outcome data on 30,000, almost 30,000 of those people. What we've learned from all these initiatives is that we can make a much bigger difference if we focus on populations with low to moderate cognitive impairment. Next slide. As a failed future farmer of America from East Texas, I've always tried to surround myself with much smarter people. So I briefly want to acknowledge a few of our partners, Alan Stevens and Jin-Myung Cho at Baylor, Scott & White. They provided the bulk of support and evaluation for our dementia projects, followed closely by Marcia Ori and Matthew Smith at Texas A&M. Janice Knavel and Jennifer Severance are partners for 8 years on our HRSA project. Marcella Nava and Catherine Daniel at UTA. And last but certainly not least, my trusted advisor for over 30 years on all matters dementia and caregiving, Nancy Wilson. Next slide. So in 2016, we decided to go all in on dementia health disparities and applied for funding from the Administration for Community Living and received that funding. What we discovered over the first 3 years of the project was there was a lot more people living alone with dementia than we anticipated. So we received an expansion grant to serve that population in 2019. Next slide. All state units on aging that oversee area agencies on aging nationwide, or most of them, require the use of some kind of a functional assessment to determine eligibility for home delivered meals and other services. We used that as a baseline in doing screening for dementia, and used that and a few questions, which I'll mention in a moment, to trigger administration of the 88. We used the QOL-AD and the Zaret burden as outcome measures, and also the QOL-AD for person-centered planning. Next slide. So we found a few questions on the Texas Consumer Needs Evaluation form that we thought, oh, if they answered yes to any one of these three questions, maybe you ought to go ahead and do the 88, which we did. And I like to say this would not have been possible without the help of Meals on Wheels of Tarrant County, which I think is one of the best Meals on Wheels organizations in the United States. Next slide. So we virtually screened all of the people getting Meals on Wheels in Tarrant County, and according to the 88, 41% of those screened had at least some possible symptoms of dementia. And about half of those, about 19% of the total over 3,000 people, were people living alone with dementia. And we were really pleased with the outcomes after we provided services primarily to address social determinants of health. Next slide. I'd never heard of culturally and linguistically appropriate services until 2015 when we were putting together our grant application, and I was told about the standards by Marcella Nava, and I thought, boy, this really fits nicely with what we're trying to accomplish with the MOS program. So Marcella conducted 2 half-day trainings for all of our partners. Next slides. And we rated ourselves the lowest on standard 11. So we decided that as a group, as a community, that we would focus on that one standard, which is to collect and maintain accurate and reliable demographic data. By doing so, we were able to increase services to African Americans, Hispanic caregivers by 17%, and services to people with dementia of color by 21%. Next slide. So we put this list together with the help of one of our dementia-capable partners in Houston, Baker Ripley. We think these are the most needed services for people with dementia. In my opinion, I think assisted in transportation and in-home visits by physicians is critical. It's a little unrealistic to expect a person living alone without family caregiver support, which is about half the people we serve, to somehow find their way into a doctor's office for a formal diagnosis, which is needed for access to services. Next slide. So only about 30% of the people we identified with the 88 as having possible symptoms of dementia had a formal diagnosis. So again, figuring out a way to get to those people, since it's very difficult for them to access medical services, is critical. I heard Janice Knable once say in one of our HRSA GWEP meetings that the future of healthcare is in the community. I could not agree more, and I think some financial incentives need to be put in place to ensure that we get more healthcare out to people, particularly those living alone with dementia. A couple of macro trends that keep me awake at night these days. One is there are more older Americans living alone than in any other country. The other trend is with each upcoming cohort, we're seeing more childless Americans. We refer to them as elder orphans. In fact, in a recent survey of Americans ages 18 to 49, 44% said they would not likely or would definitely not have children. So those days of us being able to rely on family caregivers to provide the bulk of care for people with dementia are coming to an end. So thank you very much. If you have any questions, feel free to email me.
Great. Thank you to all the speakers today. We'll just wait just a second for them to all get on video again. It takes us all a couple minutes to find those buttons. So Don, since you're available, the first question I have is the de-identified data that was collected on the AD8, is that available to people for research purposes?
I would need to check with Alan Stevens and Jin Myung Cho at Baylor Scott and White. But yeah, just shoot me an email and then let's see if that's possible.
Great, thank you very much. And Dr. Navar, so when you see patients in clinic and you're trying to help them reduce the risk of all these bad things that could happen, what do you wish they would tell you, or what things they'd be honest with you about that could help you help them better?
So I like my patients to be honest with me about everything. And I think that people often feel like reluctant to just tell me all the things that you think you could do better with. And our job as doctors isn't to judge or, give you a report card. And I think people often feel afraid to sort of be fully transparent because they don't want to get a bad grade from their doctor or hear all the things that they're doing wrong. The reality is, yes, in an ideal world, you do everything right. But the good news is you can get a benefit from each of these things independently without having to do them all. So let's say you have a physical impairment and you can't exercise, or you have chronic arthritis and you just can't increase your physical activity without substantial pain. That's okay. We can give you some ways to eat healthier. We can help you quit smoking, and we can control your blood pressure. So, both sharing everything that you're doing honestly, but also being honest with your doctor about where your challenges are. To be honest, it's great when somebody says, look, doc, I'm not going to quit smoking. You can talk to me all day, ain't happening, but I will take a statin. Great. Help me figure out ways that we can work together and find modifiable risk factors rather than sort of have me kind of shooting in the dark.
Great. Thank you very much. Dr. Sherry, the new goal from the national plan is talking about risk reduction. Can you give us a brief, so what is risk reduction versus prevention? Are they the same thing?
Thank you so much, Dr. Reguire. What an excellent question. I can tell you how we are conceptualizing the difference between risk reduction and prevention in the context of this new goal. We think of risk reduction on a population level. What are the things that we can do that would reduce the likelihood of a group of people overall developing dementia? Whereas when we think of prevention in this specific context, recognizing that a lot of people use these terms interchangeably, we think of the distinction as what can we do to stop a person from getting dementia altogether? And so that's the distinction we draw, and we do it in part because we recognize, as our presenters have so eloquently described today, that the science and our understanding of what factors contribute to developing Alzheimer's disease is still evolving and is complex. It appears to be a multifactorial illness and condition. And so it can be that addressing one risk factor, such as hypertension, can reduce the risk, but may not prevent it altogether because there are other factors that contribute to this. And so in our approach, we have tried in using the term risk reduction to acknowledge the limitations of what the research tells us right now, and that we have unfortunately not, despite through goal 1 of the national plan really driving towards it, and we haven't given up, but we have not identified that one kind of silver bullet intervention just yet that can prevent a person from getting Alzheimer's disease. But importantly, we have identified all of these other risk factors that we can intervene on to reduce the chances. And we want to be very clear when we communicate to the public that doing things like keeping your blood pressure under control, exercising more, being more cognitively active. These are so important because they can reduce your risk, but we also want to be clear that we don't yet have evidence that they will stop you as an individual from developing Alzheimer's dementia altogether. I hope that addresses your question.
It did. Thank you very much. Matthew Baumgart, is there any risk reduction data relating to American Indian, Alaska Native people and tribal communities with dementia?
So data in that population is very hard to come by. There are a couple of things that we do know. As I mentioned on one of my slides, more than 2/3 of Native Americans have at least one of those big 5 risk factors: hypertension, diabetes, obesity, smoking, or physical inactivity. And we also know that in general, the prevalence of a lot of risk factors is much higher among Native Americans. A lot of these conditions are much higher in general among Native Americans, particularly when compared with whites. And the other thing that we know, and I think you were actually involved in the study that looked at this and published a couple of years ago, that between 2014 and 2060, so over that time span, the number of Native Americans with dementia is expected to increase 5-fold. And so that is a huge increase in the population. And part of that is improved healthcare in general, so people are living longer. But it's also probably a factor of the higher prevalence of some of these risk factors.
Thank you very much. Dr. Baker, can you comment on the effect of chronic sleep deprivation and its potential impact on dementia?
Sure. This is a new area that's getting a lot of attention now. Sleep quality and cognitive health and decline. And the latest science that we're learning about suggests that during sleep, a very important process takes place. And I always like to think of it as the brain takes out the trash at night. And if we do not get good quality sleep, well, we know what happens in our houses when that doesn't happen, right? Well, so why would we expect anything different? So if we can't take out the trash, and just every day that when we're thinking, everything that we do with the brain, there's byproducts that we have to. There's extra. There's trash that needs to be disposed of at the end of the day. And so what we're learning is that people who are not getting good quality sleep have a higher buildup of this trash. And so what we've seen in science is there's a higher buildup of the amyloid protein in the brain for people who have chronic problems with sleep. Sleep comes in all shapes and sizes. Poor sleep comes in all shapes and sizes. So, poor quality can relate to not having enough sleep. It could be related to sleep apnea, where you have insufficient oxygen supplied to the brain at night. It could be related to disturbances that occur or exposures, other exposures that happen that disturb the quality of the sleep. So one of our risk reduction mantras that we have is really pay attention to your sleep. And there's some nice tricks that are well established. You can find them in many different sites. NIH has some strategies as well to help some behaviors that you can try that are important to try to protect sleep. And I just want to say, if you have or you suspect sleep apnea, I strongly encourage that you encourage your people that you work with to get that checked out. We're learning that treatment of sleep apnea can have significant impact on cognitive trajectory over time.
I have to just jump in and make a plug here for the heart too on sleep. We have a lot of data that shows that not just not enough sleep, poor quality sleep, but even irregular sleep can increase your risk of cardiovascular disease. Sleep apnea, also untreated, causes hypertension and other heart problems. So there are things that we can do medically to help you sleep better, including referring you to a sleep study, but also some, simple things, or maybe medications you're taking or other things that you're doing that may be affecting your sleep that we can help with.
Mm-hmm.
Well, thank you all very much. This was a very informative session, and I want to let you know that this is a webinar series that happens about quarterly. So please check out the website that is shown here on this slide, and you will see the next webinars. And also, if you missed this webinar, well, if you missed watching it and you want to make sure your friends see it and your colleagues see it, you can send them, the recording will be posted as well. So once again, thank you all. Excellent presentations, and thank you for participating.